Welcome to read an article site, learn, search, and get updated. This is a dental case study for 8-year-old girl with unerupted molar. The source is drbykasbet.com. An 8-year-old girl and her parents were at the pediatric dentist's office after being referred by a general dentist because the patient's first mandibular right molar hadn't erupted. The girl past medical history was unremarkable and she hadn't allergies. The extraoral exam was within the normal limits. The intraoral exam revealed that the tooth 30 wasn't present. The teeth 3, 14, 19 were present. There is no sign of inflammation and there was no pain with palpation of the area. This is the clinical picture. The pediatric dentist ordered a panoramic film. And this is a cropped view of the interested area. The pediatric dentist noted a radiolucency associated with the lower right first and second molars. She decided to consult with an oral radiologist. What is the least likely preliminary diagnosis? What is the least likely preliminary diagnosis? It's idiopathic bone cavity. The oral radiologist evaluated the films a few days later and provided a report to the pediatric dentist. There is a radiolucent lesion, oval, well-defined, well-corticated, located at the right mandibular angle. The lesion involves the first and second permanent molars. The first molar is displaced as well as the second molar. No evidence of root resorption or periosteal reaction. The pediatric dentist referred the patient to an oral surgeon who ordered a CBCT scan. Sagittal, coronal, and axial views of the posterior right mandible are provided. This is a sagittal view. This is a coronal view. This is the axial view. The oral radiologist looked at the CBCT images and added the following report. There is a hypodense lesion, radiolucent, at the right posterior angle of the mandible. The lesion is well circumscribed and well defined. It measures 20.5 mm superior inferior and 18 mm anterior posterior. There is evidence of expansion in coronal projections. The lesion is well corticated. The inferior alveolar canal is apically displaced, but it is well observed. The histologic interpretation, the definitive part of the diagnosis. The oral surgeon scheduled the patient for excisional biopsy. A photomicrograph of the excisional lesion is provided. The following paragraph is from the histopathology report. The macroscopic evaluation reveals a fibrous wall containing variable amounts of myxoid tissue and odontogenic remnants. The cyst is lined with a non-keratinized stratified squamous epithelium consists of mucospacious, ciliated, and rarely sebaceous cells. What is the most likely diagnosis? Dentigerous cyst. Case discussion. A dentigerous cyst is a non-inflammatory odontogenic cyst lined by a keratinized epithelium. The cyst encloses the crown of an erupted tooth at the cement-to-enamel junction. Dentigerous cysts are the second most common type of odontogenic cyst after radicular cysts. The cyst originates from the separation of the follicle from the crown of an erupted tooth. The mandibular third molars are most commonly affected. The mandibular third molars are the most commonly affected. Dentigerous cysts are most often found during the first and second decades of life, and there is no gender predilection. The cysts are usually discovered when radiographs are taken to investigate a failure of tooth eruption. There is usually no pain or discomfort associated with the cyst unless it becomes secondarily infected. From a radiographic standpoint, the dentigerous cysts are completely radiolucent, well-defined, and well-corticated, and they extend from CEG to CEG. Dentigerous cysts are associated with tooth displacement and, in some cases, with tooth resorption. Advanced imaging techniques are often indicated, CBCT or CT. Most dentigerous cysts are solitary, and the final diagnosis is by histopathology. Treatment is complete enucleation of the lesion, and the prognosis is excellent. Thanks.